female who presents with a 77-year-old female has a headache that's gradually getting worse over months, and she has bumps on her forehead.
Hey, so it's female with headache and some skin manifestation with bumps on her forehead. So first, I think the first symptom, of course, we see is headache. And for headaches, when I think of headache, I try to think first, okay, of course, you can go into specific headache history, but there's the primary and secondary headache. So primary would be things like migraine and the autonomic headache syndromes. But I think with this case, I jump very quickly to assuming this would be secondary headache just because we have other associated symptoms with it as well. And then, of course, I still want to know if this is the first time she has headaches, what the quality of the headache, and if so, like headache history, I would take that too with this. And then because a headache is a very unspecific sign, I try to find other symptoms that I can like connect to the headache. And so far, all we have is that it's getting worse, which is already worrying. It's for months, so it's like a subacute to chronic process. And we have these bumps on the forehead. Now, I don't know what these bumps are. I would probably want to look at them and see whether they're just like elevations in the skin or actually like discoloration or ulcers or something else as well. But yeah, those are my first thoughts for now. I don't know, Robbie, what do you think?
I completely agree with you. I think it's absolutely superb. And you've laid out a great roadmap for us to follow, which is focusing on the headache. Are we going to, is Andrew initially setting us up to be distracted, as is true in real life, and that we'll find something else much more powerful to focus on? Or is the headache the entire diagnostic space? And you'll see that whenever headache is the focus, we focus on it. But whenever headache is a small part of a big puzzle, it often gets ignored. And so that's the key question, which you've aptly put out. And I'll just point out one nuance, which is when something has been going on for a long period of time, our instinct is to immediately jump in and call it subacute or chronic. But there's a very, very easy way we can slip up by being fooled by recurrent acute disease. So let me tell you how this got hammered home, and it is actually going to spoil the upcoming RLR case on Patreon. I had a patient with HIV who came in with 3 months of diarrhea, but then, long story short, found out that he actually was having recurrent acute episodes of diarrhea from getting infected by different organisms as a result of his eating habits. And he kept eating raw food and kept getting infectious diarrhea. And I was like, oh my gosh, like here I was thinking chronic diarrhea, but in fact, he was just having recurrent acute disease. So could this person just be having migraines over and over and over again, and that the migraines are getting worse? That's another way you're going to get distracted, but that's real life, right? And in VMR, whenever you invest in long-term diseases, probably subacute or chronic, but I would say in real life, take a moment whenever things are in the subacute to chronic route to try to tease out, is it recurrent acute or is it subacute / chronic? Because we all know if we get the time course wrong, we stray very far from the right path. So probably going to be subacute or chronic here, but I couldn't help but share that practical pearl in real life. So take a few minutes here to really figure out, do you have symptom-free episodes? Do you have days where you're actually fine and then come back to feeling worse? That one question will be really key. All right, Andrew, back to you.
All right. This is a 77-year-old female who has bumps on her forehead. It's off to the left-hand side of her forehead. She's had a gradual headache that's worsened over the past 2 months, and the bumps have been getting worse over that same time period. The headache is unremitting. It's very constant. It's completely non-positional. Nothing makes it worse, and nothing really makes it better. In addition to the headache, and she says it's not radiating pain, it's something separate entirely. She has pain on her forehead, pain in her ear, pain temporal mandibular junction. It's kind of all over her face. The lesion on the forehead is very subcutaneous. It's about 3 centimeters wide and it's hard and lumpy. I can tell you more associated symptoms if you'd like to hear them. She has blurriness in the same eye. It's very mild so far, but it has been getting worse. And finally, this person had pretty constant nasal drainage, prolonged rhinorrhea that was starting 6 weeks ago and was chronic over the course of at least 4 weeks.
Wow. Okay, this is getting very interesting just because there's so many elements to it. And thank you also for presenting it so so nicely, describing it. I think so. One thing that changed in my thinking was now the headache is less just something within the brain or like the yeah, intracranial for me, because the headache can be unspecific, a systemic symptom as well, or it can be on the head, like if you have something localized here. And to me, because we have so many manifestations, it could also be one of the explanations for the headache. And so because it's blurriness, it's affecting the eye, the ear, and it's getting worse. So I kind of get the feeling that it's something that spreads and is growing there. So I wonder, does she have fever or any other signs of inflammation that would clue us more into, okay, this could be an infectious process, or what kind of exposure did she have? I think this is the first time I have this combination of manifestations, but I'm thinking maybe some kind of fungal disease could do that. For example, if she had risk factors like diabetes, like a mucor, which can be quite an aggressive fungus. I'm not sure if this subacute process would be too slow for that, but it's definitely something that can grow fast through body parts. And then also, yeah, maybe in this situation, it would be helpful to get a bit of tissue to just see what there is. Those are, I think, yeah.
I'm gonna share screen
And
if I can find a picture, because that's something you'd like. I'll show you this person's exposures and we'll carry on from there maybe.
Yeah.
All
Sounds
right.
good.
Let me see. One moment. Let's see, I'm going to try to share screen now. Yes, here. Okay. Do you see the young lady that I'm looking at? Okay. This is a stock image. This is not my patient because the patient was actually an elderly 77-year-old. The lesion was to the side of the forehead and a little less erythematous than this. As you can see, it's very deeply subcutaneous. It's hard and it's very lumpy to the touch. It's about 3 centimeters in width. I can describe the physical exam if anyone else. In fact, I'm going to stop screen sharing now that everyone has seen this. We'll go back to the whiteboard.
Yeah, Andrew, maybe it'd be helpful as we analyze the foreground for you to paint for us what the bottom left corner is, the medical history, the meds and whatnot, to sort of round out the story here.
I'm ready. Here we go. This patient has the history that involves half a year ago, she had a 7-week-long COVID pneumonia hospitalization. She had complications of the COVID pneumonia that kept her in the hospital for 7 weeks with aggressive proning, with pretty constant corticosteroids on the ARDS protocol. She had UTIs. She was intubated for at least 4 or 5 weeks of that time. And she got out of the hospital saying that her head felt swollen all the way around. This patient has fairly thin skin. There was a skin breakdown across her hand, just like getting out of a car or something like that, that completely shedded 3 inches of skin down her wrist. So there's profound skin breakdown. The patient did have a fall, but she insists she didn't hit her head. She is pre-diabetic. She had an A1C at 6.5. That was the highest she's ever had. And things have been getting worse in the past 2 months. That COVID hospitalization was 6 months ago. Then she was stable for a while, and the past 2 months she's been having sinus drainage, a little bit of blood mixed in with the sinus drainage. Let's see. Other surgical history includes a knee replacement and a hysterectomy. She's been taking levothyroxine for hypothyroidism. That's just about all I can tell you on this patient. All right. Would you like to see physical exam findings?
Yeah, maybe we can stop
Look up.
after the vitals and physical exam to reflect.
Here comes.
Yeah, perfect.
All right, the vital signs show systolic 151 over diastolic 59. These are widened pulse pressures, but that was very much this patient's baseline for some reason. Heart rate was normal at 75, respiring normally at 16 per minute, satting 99% on room air. Without a fever in her history, she was 98.3. And her pain was described as a constant 6 out of 10 headache. At 98.3 degrees Celsius. Fahrenheit.
Fahrenheit. Yeah. Okay. Sorry, I'm just not used to Fahrenheit. Does anybody know how much Celsius? Okay, thank you, Nikita.
Thank you.
Okay, so I'll just share a few thoughts for this. That's all right. So we have basically the vitals are not too worrying if we just look at that. The past medical history, though, is kind of, to me, because there was a lot of complicated courses of diseases that she had, and also this this long course of the COVID pneumonia. My assumption is that maybe because of comorbidities she has, she's maybe also more predisposed to having long and difficult courses of the disease. And there might be some undiagnosed diseases because, you know, we see the elevated ABA1C. So maybe just, and also the UTI. So I feel like her body is not in a good state to fight off infections well, just based on the past medical history. And that might also play into her presentation now at the moment. And maybe that's also why the vitals are not showing that much, because she might be compromised with the way her body reacts to diseases at the moment. But that's all that I can say out of these two things.
I agree. I think you have to like maintain a distance from being committed to a certain pathway because you haven't gotten anything that allows you to propel you forward. And I think that you're analyzing the headache, as you discussed previously, you're analyzing the headache and the skin findings separately. But it did prompt you to acknowledge acknowledge the common reality that patients have headaches because of face issues. And you can have skull-based osteomyelitis, you can have zoster that on the skin that causes your head to hurt. So that acknowledgement is important. But I think right now all you can say is you have essentially 4 threads to follow. She has a headache, she's got skin lesions, she had COVID, and she has pre-diabetes, and how all those will merge together is actually very tough to figure out. But I think it's so wise of you to separate them, because she could have a dural venous sinus thrombosis as a consequence of COVID, and that can cause persistent headache. And then the COVID could be immunocompromising her and have resulted in mucormycosis, or you could have mucor with a thrombosis. So the truth is, right now, you want to gain clarity on each of these problems. So what is the nature of the headache as it appears on imaging? Is there something in the brain? And then analysis of the peripheral signature of this possibly infectious process. Does she have eosinophilia? Does she have leukopenia? Will be really, really informative. So I think what you are showing us in your modeling is the importance of knowing when to start to tie things together. And now if you started to lump things, I think you're at the risk of missing something. So if you lump the headache and the skin lesions and just said, oh, she's hurting because she has subcutaneous bumps, you might miss an intracranial process. So I agree with you. Let's keep all our doors open and we'll see which one Andrew guides us down.
I'll summarize. My mic is on. I'll summarize the physical exam findings for you if you like. There was exam showed a collected, thin and fatigued woman in an atraumatic state who was anxious. She didn't know if she had a sinus infection that was causing a problem, or she was scared by possibilities of cancer. She was frankly very terrified when we saw her. But her exam showed that eyes were behaving perfectly with external ocular movements intact, with reactivity to light, with no periorbital swelling on either side. Her ears were absolutely within normal limits. The nose had a perforated septum that was related to her childhood that was stable. There was, at this time, there was no further rhinorrhea. That was actually resolved. Cranial nerves 2 through 12 were intact. She had normal gait. There was no true neurological findings of dysarthria, dysmetria. Cardiovascular exam was normal. Pulmonary exam was normal. For this patient who had a localized process that seemed to be infectious versus malignancy, we wanted to make sure we got appropriate labs. We collected a CBC, renal chem, with blood cultures. We repeated our A1C and found that it was back down to 5.4. We ordered head imaging. We ordered a PET CT scan and an MRI. And with the possibility of an infectious process or an oncologic process, we consulted neurosurgery, we consulted oncology, and we brought in infectious disease. We didn't consult ophthalmology at this time, despite the blurry vision. And I don't know if I would do that different looking back. Her labs were largely without dyscrasias, save for a white count of 11.1.
Okay.
Do you want to give us the results just because I think we only have 7 minutes left?
Of course, here we go. The
Yeah.
MRI and PET CT showed a lesion that exhibited bony sequestration in the frontal sinuses. This from the MRI said that osteomyelitis seemed more likely than a local malignancy. But there was no sign of pneumocephalus. We were instantly worried for expanding osteomyelitis. And so we started the patient on ertapenem and vancomycin. There was a beta-lactam related allergy. There was no pneumocephalus.
Can I clarify? What did the PET CT look like?
I don't interpret very many of those.
Oh, no, where is it all? What was the radiology read on the PET CT?
It focused on the bony sequestration in the internal facing cranial findings. It involved the epidural space and was right up against the dural.
Gotcha. And so thankfully, there's nothing else in the body that the patient had. So we can sort of summarize this as the PET-CT helped us confirm that the MRI findings are really the only thing that this person has. Is that fair?
Yes. There was nothing. There was an incidental thyroid finding that they emphasized was absolutely incidental.
Perfect. Awesome. Well, thank you. I think we can unleash Leah's wisdom on this, on these findings. So yeah, what do you think? Andrew's really setting us up quite a
Yeah.
doozy here.
It's a really interesting case. I think when I just read or heard the clinical exam, at first, okay, there's not really much noise for neurologic symptoms. Then again, sinus thrombosis can present with so many various things, so you can never exclude that. But I guess there's no noise that, like, if there were a lot of neurologic symptoms, it might cue me more into that, but not having them is not helping me in that sense. But then having the imaging now kind of might explain that it's more an external or localized process because we don't see anything in the brain itself. But then, yeah, I'm not too sure, but because the rest of the exam and also the labs are not too worrisome, I feel like something as aggressive as mucor would be less likely at this point. And I think maybe just like a localized bacterial infection that happened to grow there and manifest itself is more likely now. So it would probably, before starting antibiotics, they probably also took cultures to find out what exactly it is. But I'm not too sure. I could just count like very common bacteria would be like Staph aureus, some kind of streptococcal infection that can be there. So yeah, I'm not sure where it comes from. Maybe it's some kind of remainder from something she picked up at the hospital or from somewhere else, but I don't think I can tell exactly. I don't know. What are your thoughts, Robbie?
Yeah, no, I think Andrew is essentially telling us that this is a case of a patient who likely has osteomyelitis of the skull base and the skull. And I think it goes to show you how hard that diagnosis is to make. This patient has been puttering around for 3-4 months with this slowly progressive disease process. And I think that the real credit to your cognitive thinking, Leah, is to not anchor on the skin being the problem and not to anchor on the brain being a problem. And the fact that you kept both doors open, now you can confidently say that the answer lies at the juncture, the bones between the face and the brain. And so I think the fact that there is no prominent peripheral process in the PET-CT otherwise tells you that either this is an aggressive local tumor or it is an aggressive local infection. And of course, there are tumors that occur in this space, but they're often in young children and not so much in older adults. So the fact that you're seeing this as an older adult makes you prioritize infection. And you already know the time course. I think that's why investing up front in the time course is important. So this is a subacute infectious disease process. And so I think the question for us to process is, well, what causes osteomyelitis in general? And then what changes because of the location of the osteo in this case? So the first one is a little bit easier because it's a bigger question than the second one. So take us where you're at with how you think about osteomyelitis in general.
So the osteomyelitis in general, I feel like most associations I have are when with like especially diabetics who have like deep foot ulcers and the bone is actually like exposed. Thank you.
Yeah.
And yeah, I don't think I have much more specific than that. So it's either the bone or bone marrow that's affected and infected.
100%. So you're right. The most common, so there are two, osteomyelitis comes in two flavors. And the first flavor is contiguous spread. So contiguous spread is osteomyelitis of the extremities, where because the skin is broken down, the bacteria from the skin can go right into the bone. The less common variety of osteomyelitis is hematogenous osteomyelitis, where the infection spreads through the blood into the bone. And that's actually the subset that I was alluding to. Because I said, hey, what are the most common causes you think about in general, and how does it change if it's in the face? Well, what happens when it's in the face is that mechanism that you just used of contiguous spread from the skin no longer applies. And so you know now that this is actually the less common kind of osteomyelitis, and it is the hematogenous osteomyelitis. And the most common places that we see that is not actually the face or the head, but the spine. So have you ever seen a patient, Leah, or heard of a patient who has lumbar or spinal osteomyelitis? Has that crossed your radar at any point?
Yes, so we have like spondylosis.
Yeah,
Yeah.
exactly. Yeah. And what do you know about that? Like what has crossed your path in that kind of osteo?
So for that, I associate it often like as a complication with like bacteremia.
Exactly.
And then also like after having like patients with endocarditis that have Staph aureus bacteremia, for example, you always want to exclude that they have these bacteria that stay there and cause it.
Exactly, you nailed it. And I'm curious, Leah, what happened there? Because you unlocked a subset of your knowledge that you had, but it wasn't unlocked initially. So what happened? What prompted you to tap into that space now compared to before?
I feel like you opening the door again for these two buckets of hematogenous and like direct spread made it much more like, yeah, right. I knew that we have like these two types. And then also that osteomyelitis is a very broad term, and we might have learned it in very different names.
Exactly.
But then actually spondylodiscitis is just a type of osteomyelitis because it's a bone.
Exactly. You know what's really cool about what you did? I was watching you and trying to facilitate and guide you, because I mean, I'm having seen you speak and comment in the chat before. There's no way that you didn't know what you just said. But it's really cool how our minds work when the same thing is taught to us, just using different words. And so sometimes we create separate files for them, and then you have this aha moment and you realize, wait, actually they're the same thing. And then the other thing too is your mind jumped to that initial explanation first in diabetes because it's way more common. So kudos to you for recognizing and not jumping into the rare spaces. And so I think we're right here. We're going to borrow from our back playbook, because this is more like spondylodiscitis than it is the regular old osteo. And in the hematogenous variety of osteomyelitis, over 50% is caused by Staph aureus. 50%. The remainder is caused by strep, and then enteric gram-negative rods like E. coli. So that's the landscape. But the problem here, my friend, is the time course. Those things usually cause acute hematogenous osteomyelitis on the order of days, and if you're generous, weeks, but months. So I think when you go into months, you have to start to entertain subacute to chronic osteomyelitis. Subacute to chronic hematogenous osteomyelitis. And that's a space where all the granulomatous infections come into play. So POTS, or tuberculosis of the spine, is the most notorious example, but any of its granulomatous cousins are fair game. So this is the time where if you're in some parts of the world, you will run and think this is brucella, because brucella causes osteomyelitis like no other. If you're in other parts of the world, not where Andrew is, you would jump to thinking about the possibility of tuberculosis or salmonella, or even Whipple's disease. But in Andrew's part of the world, fungi are rampant. So the possibility of an endemic mycosis, blasto being the champion, followed by histo, are really, really important considerations.
Arkansas
You
is
can't
the
put them.
blasto capital of the world.
It is the blasto capital of the world. It is. And so that has to be really, really important. But I also wanted to share that if we stop borrowing from the back and actually say, what organism has a propensity to cause skull-based osteomyelitis alone? And the answer is syphilis. How do I know that? Y'all must remember, some of you might remember Gabby's incredible VMR. Yep, you remember that? Where she taught us that syphilis almost never goes to the bone except in skull-based osteo. So we're just rambling here. Here's the truth. Here are the truths in these cases that Leah illustrated. When somebody has a headache, the problem, if somebody has a secondary headache, the problem may not be in the brain. Think of the eye like glaucoma. Think of the face like skull-based osteo. Sometimes the neck with carotid dissection can actually present as a headache. That's lesson number one. Lesson number two is when you have osteo, you have to figure out, is it contiguous spread from a skin ulcer or is it hematogenous? Those are very, very different diseases with different microbiology, different treatment. And the name of the game here is biopsy the tissue. So I'll pass the mic to Andrew to take us home.
That's exactly what we did.
Yeah, what did y'all do? What did you find?
The biopsy with tissue was done endoscopically to the sinuses and with a frontal approach, unhelpful. We did not find actually pertinent pathological findings or cultures coming out of that. And so we just went for source control on the infection. A couple days later, that was on Friday, put the patient on ertapenem and vancomycin while getting source control via craniectomy. Big surgery. During the craniectomy, the plate came off with quite a bit of attachment to the dura mater, and there was a tiny bit of CSF leakage that was managed by a pulsatile CSF leakage that was managed by tamponade by the surgeon. And so there was, CSF exposure of the infection. We kept them on ertapenem and vancomycin until 4 days after surgery, when a pathologist put on his cape and boots and saved this patient's life. Because ertapenem and vancomycin did not offer coverage for what he found, which was branching hyphae on bone and epidural biopsies. It was a fungal process for which we did not have coverage. We went back in the patient's history and saw that in addition to the extraordinary corticosteroid dosage of her hospitalization that had actually continued since the hospitalization, she had been prone on her forehead for 5 weeks. This had caused a local sore on her forehead with skin deconditioning, so that what we thought had been hematogenous spreading was actually a local exogenous source of mucormycosis that had been chronic in its localized spread towards the dura mater for several months. It blew us away that mucor would be slow spreading when it's always so renowned for being extraordinarily fast in people who are immunosuppressed with dexamethasone and diabetic or pre-diabetic. But we instantly discontinued dexamethasone, induced the patient on liposomal amphotericin B with the appropriate prehydration, and after a week of induction, transitioned to Cresemba. The patient did not require any further surgical source control. The orbit was actually spared, and she's still living.
Andrew, before it vanishes, take a look at the chat. Take a look at the chat. In the meantime, Leah.
Wow. Okay. So I think, first of all, thank you, Andrew, for this case. I think it's one of my favorite cases just because the way you presented it.
I timed it. You said mucor 9 minutes into the presentation. You got it. Bravo. But then it tried to hide from us.
It was like were so many twists along the course also in this case. And thank you also, Robbie, for sharing your approach to osteomyelitis. I think because I got to discuss this case, it will remain for a longer time in my head now. But yeah, I think I have a lot to learn from this and also still continuing and thinking back on it. But thanks again, Andrew, for this amazing case.
No, listen, I mean, I don't, I don't know why the whole world isn't on VMR to watch Andrew storytell. Like anyone remotely interested in medicine, be it in medicine or people who read the New York Times diagnosis column. And honestly, watching you present reminded me a lot of Lisa Sanders. We were very lucky to have her present cases to us. And if those of you who don't know her, she actually does, to Amber's point, have a next Netflix documentary series about diagnosis and writes a weekly column in the New York Times. She's an incredible storyteller. And Andrew, I think that she may have found her successor in your ability to tell diagnostic stories. Oh, it's so cool. And you kept your cards hidden to your chest the whole time and then revealed them in such a illuminating and educational way. So thank you so much. And I can't imagine what it was like to take care of this patient. So I would just say it was a privilege to co-facilitate with you, Leah, and to see how comfortable you appeared to be outlining your thinking and defining the limits of it, and also how vulnerable it can be to showcase the growth of your knowledge in real time. And I thought it was really cool to see that, to be like, oh yeah, no, I do know hematizing osteo. And it turns out that I misled you, that we should have stuck with your original thought of contiguous spread. But I don't know if I could ever see that coming. So
We certainly didn't.
yeah. So I'm curious, Andrew, what was it like to make that discovery? Like, how did it feel to make that discovery?
Because this was the second patient with Mucor in a pre-diabetic state that I've seen, I felt like an imbecile. But you've got to catch Mucor, right? I'd previously had a patient who was also pre-diabetic, never diagnosed with diabetes, who was actually passed from mucormycosis. And so cold chills down my spine when the pathologist actually caught something that we had neglected. But we had no indication because everything seemed to point to a bacterial osteomyelitis. And we were even saying to ourselves that we've got pseudomonal coverage. This patient should be fine. It reminded me that there's a lot of cognitive discipline to be learned still.
Superb. I feel like there's a reasonable chance that we'll be in a few years' time, you will be on Monday via VMRs as the ID specialist, joining us to share your expertise after presenting many a case. I can see that as a possible outcome of the future. It's really
Thank
cool.
you.
Yeah, of course. All right. This case is totally worth going over time for. We can't not listen to Promise's wisdom as she recaps the case. So Promise, take it away, please.
Can you hear me?
Yeah, I can hear you now. Perfect.
Okay, well, first of all, thank you so much for this wonderful case and the way you tell the story, Andrew. I think it's very admirable, and I've definitely learned a lot. So we started with a 77-year-old female presenting with headache that has been chronic and worsening for months and notable for a bump in the forehead. And so Leah pointed out with headache, the first thing she thinks about would be whether or not if this is a primary headache or a secondary headache, which would involve some kind of alarming symptoms or some sort of associated symptoms. And when we think about headache, we shouldn't just think about, I guess, the brain, but we should also think about the eyes, the skull base, the face, and even like a carotid dissection in the neck. And we talked about how this patient has blurriness in the eyes and nasal drainage. So all of these would kind of point us towards thinking of an infection disease cause. And we talked about Mucor in the beginning causing a headache. And then when we found out this patient is pre-diabetic and also have a complicated past medical history and had been on steroids, so she's probably immunocompromised. We talked about how that could maybe the reason for her pretty insignificant vitals and physical exam findings. And then I think something really important to think about is the time course of this patient. The way it presented, is it subacute, is it chronic, or is it recurrent acute disease? And we also really want to localize where this headache is coming from. Is it intracranial or is it external source? So Leah really hammered that in, and she was suspecting like an external Mucor in the very beginning, but we kind of got sidetracked by all the other information. And we were really thinking about like an osteomyelitis in the school after we saw the MRI and the imaging. And we talked about how when there's whether we should think about a tumor or an infectious picture. And there are two types of osteomyelitis spread. One is a continuous, one is a hematogenous. And with something that's more subacute and chronic, it's osteomyelitis, we would think more into like a Pott's tumor. And also for skull-based osteomyelitis, it would very likely be a syphilis, but this case pretty much surprised all of us by having a very naughty mucor hiding in the bone because of the steroid use and her pre-diabetic state. So thank you so much, everyone, for your participation, and it's been so fun learning with everyone. It's a great case.
Thomas, that was superb. I think the two biggest reasons it was so good was one, it was so concise and hit the high points. I think there were a lot of like micro learning points that I think you let be and focused on the highlights. And two, I think picking up on the theme of the nasty and angry mucor and like personalizing it was really, really cool. And certainly will stick with me. All right, y'all have a great day. Hope to see you all.
Thanks very much, Leo.
Thank you, Andrew. Bye.